So I will speak about intracorneal segment implantation, case of success, and I will speak about the planning. The most important thing is to plan. To have a good result, you have to have a good plan. So which are the indications? How can I do this? Okay. So intracorneal segment in keratoconus, we have to indicate in low uncorrected visual acuity, in low best corrected visual acuity, when a person cannot see with glasses, but with high potential. It means that we can see with contact lens or rigid contact lens or scleral lens. And when contact lenses are not accepted, the ring is not the first therapy. The first therapy is contactology. Indications in advanced cases, central scars, very thin cornea, uncontrolled immune. So there are some cases that we cannot indicate rings. I will do very fast because it's long. So when we work on cornea, when we do refractive surgery and keratoconus, we have to know this by heart. The aberration, we are working with aberration, and we have two kinds of aberration. We have low order aberration that are myopia and astigmatism. They focus on astigmatism. And we have high order aberrations that are coma, high spherical aberrations, secondary astigmatism, and others. So when we use intracorneal rings, there are, it is like refractive surgery. We have in refractive ablative surgery, we have ablative profiles. So in intracorneal, in additive refractive surgery, it's additive profile. So we will study the additive profile of myopia. It's a ring, it's a 360 ring. In astigmatism, we have two parallel rings, segments. In coma, we have one ring from one side. In high spherical aberration, we have the circular ring. And in secondary astigmatism, which is a high order aberration, we have the two parallel segments. So we will play with these tools to treat our keratoconus. So we have different kinds of rings, Carrara, Ferrari, Intax. We have different characteristics of a ring, diameter, the thickness, and the angle of the ring. We have the asymmetric rings, but the most important is to reach the goal. What is my goal in this treatment? It is to increase the best corrected visual acuity, to increase the uncorrected visual acuity if possible, and to reduce aberrations. So we have to determine which is your first enemy. What is your first enemy? It's up or down. Your first enemy is down because your first enemy is high order aberration. And you see that astigmatism is in low order aberration. So astigmatism is not your first enemy. Your second enemy is low order aberration. So you have to make a strategy in your treatment and a strategy against high order and then low order aberrations. How to calculate the ring? This is the most important part of the surgery. You have to determine the sphere, the cylinder, the visual acuity, the axis, and the depth of tunnel. And I use also the angle. So the sphere, you can do it subjective, no cycloplegia. The cylinder, it's better to do it subjectively. The best corrected visual acuity will give you information. If you have a best corrected visual acuity that is good, it means that the problem is only low order aberrations. When the best corrected visual acuity with glasses is low, it means that your problem is high order aberrations. The determination of the axis, will you use the coma axis or the topographic axis? It is important. The myopic pupil, if the pupil is wide, you have to go through wider rings. The depth of the tunnel should be 70 or 80% of the depth of the cornea. The axial length, I use it because it helps me to determine the defocus. So I will not do the same treatment, the same program with an axial length of 30 millimeters, that 20 millimeters. The goal is to avoid hyperflattening of the cornea and to have a prediction of refraction after the ring. Sometimes you have a patient with high myopia, axial myopia, and a keratoconus like this. You have a keratoconic patient with emetropia and keratoconic patient with axial myopia. So the program will be different. For example, if you take this refraction with these two keratoconus, the keratoconus nomogram will give you the same ring. The same one. Is it a good plan for both cases? No, because the axial length is different, and because the aberrations are different, and in the left side we have the problem is high spherical aberration, but in the right side the problem is coma, so you cannot treat them in the same way. That's why the management, when you take in account the axial length, you adapt, you adjust your treatment. So what about the nomograms? Nomograms are given by firms and manufacturers. So this nomogram have the advantage that they are systematic for beginners. You can have good results when you have best corrected visual acuity, because they give more importance to low order aberrations. But they have a lot of disadvantages. You have bad results when you have the best corrected visual acuity is low. It doesn't take in consideration the amount of high order aberrations. It does not take consideration the level of asymmetry. Keratoconus with coma is asymmetry. It does not take the Q value, the asphericity. So are there nomogram published? No, there are some mathematical calculations, and it is not a dogma to follow these nomograms. So I give you some examples. This keratoconus with this refraction, the nomogram will give us this ring, and this keratoconus with the same refraction will have the same ring. So do you imagine that we can treat these two keratoconus with this difference by the same ring? No, because the coma is different, and because the nomogram should include asymmetry. So my personal method, taking consideration low order aberrations, using pinhole, using the long axial length, high order aberration, when best corrected visual is low, asymmetry, it gives us the coma, Q value, and axial length. So when you have the coma axis parallel to topographic axis, that's why you have these kinds of rings. You have one big ring, or two parallel rings, or two asymmetric rings. This is to understand how the nomogram works. And when you have the perpendicular, the coma axis perpendicular to topo axis, you have one big ring from inside and one small. The implantation is not an issue, because you can do it now by femtosecond. And how to judge results? You shouldn't use the refraction ticket, because the refraction is not a good tool to evaluate keratoconus at all. But you can evaluate by uncorrected, by best corrected visual acuity, K-max, Q value, etc. So we have some clinical cases used with the nomogram that it doesn't work, because the nomogram they don't take in consideration the asymmetry. But so I have not enough time to detail all this. So I give you one case. In this case, we have this asymmetry. We use this ring, and you see that the regression of the cornea and the visual acuity were 1 to 10, and after the surgery it was 7 to 10. So the ring is the plan. Intracorneal is the plan, and when you have a bad plan, you have bad results. And thank you very much. Thank you.